Thank you, Mike, and thank you all for making time for this presentation. And thanks to the organizers as well for allowing me to present at such short notice. I want to take maybe 25 minutes to take you through some of the work which I've been involved in that forms a big part of my PhD, and explains that what I think is an interesting story about how guidelines have been developed for pneumonia in children in Kenya, full circle from an initial guideline development meeting to generating primary evidence based on gaps which were identified by a guideline panel, and revisiting the same questions again to review whether the guidelines should be changed or not. Right, so to start with, I'd like you to imagine you're in an outpatient department. So this is a young girl, a year-old, presented to the outpatient department of a typical Kenyan hospital with what we call lower chest wall indrawing. So the lower part of her chest was being pulled in due to what was presumed to be an infection in the lower respiratory tract, and she was diagnosed as having severe pneumonia. And the guidelines, as they were before this set of meetings, which I'll describe in this presentation, recommended that these children be admitted and treated with injectable antibiotics in hospital. And this recommendation was based on reasonable evidence from etiological studies conducted in low-income countries in the 70s and early 80s. So this slide shows a review done by Frank Shan, where he looked at evidence from developing countries on the etiology of pneumonia in children. And just to summarize, the paper reports that 62% of the children who were included in these studies had bacterial etiologies, and 23% had viral causes for their pneumonia, with some overlap between the two. And drilling down further in the same paper, the specific bacteria which were identified as predominant causes for pneumonia were Streptococcus pneumoniae, Haemophilus influenzae, and Staph aureus. And based on this data, the WHO, through the acute respiratory infections technical working group, developed guidelines which recommended stratification of children into levels of severity to inform the antibiotics chosen for treating these children. So based on simple clinical signs, children would be categorized into one of 4 levels of severity, with the most severe being children termed as having very severe pneumonia, defined by the presence of central cyanosis, grunting, inability to drink, head nodding, and altered consciousness. So important to note there is some of those signs are actually not primarily, they don't primarily define children with pulmonary illness. Specifically, things like altered consciousness and inability to drink are fairly non-specific. But these guidelines were deliberately created to be more sensitive than specific, to make sure that they capture the majority of children with suspected life-threatening pneumonia. So children with severe pneumonia who include the child who was in the first slide with lower chest wall indrawing, in the absence of the so-called danger signs of children with very severe pneumonia formed the next level of severity, and then children with pneumonia were those who had fast breathing in the absence of those additional signs of severity. So children without signs of severe pneumonia and very severe pneumonia, and then there will be children who would be termed as having no pneumonia if they had none of those signs above, but presented with a cough or difficulty in breathing. And based on these signs, children should be treated with antibiotics reflective of the severity of their illness. So children with very severe pneumonia would be treated as inpatients with injectable penicillin and gentamicin. Those with severe pneumonia would be treated with penicillin alone, and it's still inpatient, and those with pneumonia will be treated as outpatients with oral cotrimoxazole, and no antibiotics for those with so-called no pneumonia. And so these guidelines have been in use for over 30 years and have been credited with reducing mortality where they've been implemented appropriately. But over time, some things have changed, and these things are believed to have influenced the overall etiology of what we term as pneumonia. So for starters, Kenya and many countries have introduced the vaccine against Haemophilus influenzae and pneumococcus as well. And you'll remember that these were the two predominant causes of pneumonia in the earlier slides, which eventually informed the choice of treatment for children with presumed pneumonia. And there's good evidence to show that since the introduction of these vaccines, the incidence of invasive disease due to these two organisms has dropped dramatically. There's also some interesting work from Pakistan which suggests that for the lowest severity of so-called pneumonia, the role of antibiotics can be challenged. So in this double-blind randomized controlled trial of over 800 children presenting with non-severe pneumonia, Tabish Hazir and his team demonstrated that there was no difference between placebo and oral amoxicillin for treating this population of children. And some of the explanations for that included possible viral infections among the majority of those children, which wouldn't respond to antibiotics anyway. There is a large multi-country study that was supported by the Gates Foundation and other partners, and some of the lead investigators include Jane, who's in the room, which looked at the causes of pneumonia in this post-pneumococcal vaccine era, and it was carefully designed and was specifically designed to provide new evidence to inform how we treat children with pneumonia in this era. Unfortunately, the results are not out yet, although there is a pilot that was published in 2012 which suggested that viral causes were more common than bacteria. So previously we thought bacteria were the most common causes of pneumonia in children, but over time evidence seems to suggest that the pattern is reversing. But perhaps the biggest test of whether or not antibiotics should be used would be clinical trials among children comparing alternative antibiotic treatments for this population of children who we still call pneumonia. So amoxicillin is an oral antibiotic, and benzyl penicillin is an injectable treatment which has a fairly similar spectrum of activity, but with amoxicillin you have potential for avoiding injectable treatments and their adverse effects, and also potentially oral outpatient therapy for this population of children. So there are 3 large clinical trials, two large clinical trials, one relatively small one, which looked at comparing amoxicillin with benzyl penicillin for children with indrawing pneumonia, like the child who was displayed in the first slide of this presentation. And they followed them up for treatment failure as their primary outcome. And all these three studies reported that the two treatments resulted in equivalent outcomes. So the oral antibiotic was as effective or no worse than the injectable antibiotic. An observational study was also conducted that looked at children receiving oral antibiotics for this so-called severe pneumonia across 4 sites, including 2 sites in Africa. And they essentially reported a treatment failure rate of 9.2%, which fell within a margin very similar to that of the clinical trials showed in the previous slide. And interestingly, none of the children across all these 4 sites died. And so given this evidence, a team of us in Kenya were tasked with revising or reviewing the guidelines for treating pneumonia in children. And some of you may have heard of the GRADE methodology. So we attempted to use GRADE to develop or review the guidelines for pneumonia among other conditions. And so we invited a panel of experts across several disciplines, including clinicians and people from the ministry, people from academia, and other partners, and presented them with this evidence, which was shown in the previous slide. And they were tasked with developing a recommendation on whether children with severe pneumonia should be treated with amoxicillin in place of the injectable treatment, which was this standard of care. So they were asked to anonymously vote on that question, and this slide shows how the panelists voted. So around 60 people participated, and you can see a large number of participants felt strongly that this recommendation should not be adopted. And one of the main reasons given for not adopting this recommendation to switch from injectable treatment to oral treatment for severe pneumonia was that mortality within African populations might be higher, and there is some evidence to support this. So this is a review that was published in 2014 looking at mortality among children with pneumonia across regions of the world. And you can clearly see that children in Africa suffered a higher risk of death from pneumonia than other regions in the world. So this somehow justifies the position of the Kenyan panelists to reject this recommendation to switch to oral amoxicillin, given the fact that the evidence which I presented was from predominantly Asian populations and didn't include very many children from Africa. So we identified 2 main gaps in evidence from this meeting in 2010, that there was uncertainty about the primary efficacy of benzyl penicillin for severe pneumonia. So should children actually be treated with a single antibiotic for this severity of illness? And there were also concerns about how amoxicillin would compare to benzyl penicillin for the same population of children. So interestingly, the WHO looked at the very same question a couple of years after the Kenyan panel, and made a strong recommendation to change to oral amoxicillin. So this is a copy of the latest version of the pocketbook, which the WHO released in 2013. And here you can see they recommend that children with lower chest wall indrawing be treated as outpatients with oral amoxicillin at the dose shown on the slide. So, given the uncertainty around that particular recommendation and concerns among Kenyan policymakers, we conducted a clinical trial comparing the two antibiotics. And we did this at 6 sites in Kenya, 6 public hospitals, including 3 sites in Western Kenya where malaria is endemic, and the 3 other sites were around central Kenya. So this was a pragmatic clinical trial which included children with numerous comorbidities. Actually, almost half of the children admitted had pneumonia and another condition alongside pneumonia. So we followed them up for predefined treatment failure at 48 hours and specified an non-inferiority margin of 7% to conclude non-inferiority for amoxicillin versus benzyl penicillin. You can see from this slide that 7.7% of the children on amoxicillin failed treatment at 48 hours compared to 8% of those on benzyl penicillin. And the upper bound of the 95% confidence interval for the risk difference of 4.3% fell within our pre-specified non-inferiority margin, suggesting that amoxicillin was no worse than benzyl penicillin for this population of children. The other question that we tried to address was first whether the primary efficacy of benzyl penicillin or indeed amoxicillin monotherapy for this population of children. So you can see here in this slide we report the mortality of children treated at the hospitals on a single antibiotic for this category of severity of pneumonia. So for the clinical trial, we had 0.8% of the children, so 4 out of the 527 children died. And we also wanted to look at those children who received routine care, because there are concerns that children treated in a clinical trial might not be representative of those who will receive care in routine settings. And so we followed up, we extracted data from children admitted at the same hospitals over the duration of the trial, but excluded from the trial, and compared mortality between the two groups. And you can see there that although the absolute rate of mortality was slightly higher among those who received routine care, shown on the green bar, this difference wasn't statistically significant. And so we could crudely conclude that mortality would be similar in routine care settings compared to the clinical trial settings. And this gave us more confidence also around how pragmatic our clinical trial was. So updating the data from the previous clinical trials, which I showed earlier, with our own data, this slide reports the pooled results from clinical trials looking at treatment failure for children with severe pneumonia. And you can see there that there's essentially no difference between oral amoxicillin and injectable penicillin, including data from over 4,000 patients. So, given all this previous evidence and evidence from our study, we approached a similar panel of guideline experts from across the country at a meeting in October 2014. and presented the same question to them, including the new evidence from our trial. And the panel felt now very strongly, almost unanimously, that we should revise our guidelines and change to oral amoxicillin on the basis of the previous evidence and evidence from our local study as well. And this revision is reflected in the most recent update of our national pediatric guidelines. So we've gone full circle, but there are still loose ends which we should probably tie up. So the evidence still shows that mortality among African children might be higher, and those concerns need to be addressed, and there needs to be an attempt at explaining this difference. And so in some of the work which I'm still trying to analyze and write up right now, I'm attempting to examine the potential risk factors that might explain high mortality among children with pneumonia, using data from a population of Kenyan children treated in routine care settings. So this is a slide which Jane shared with me, which sort of explains the rationale for this additional work which I'm trying to conduct. So the WHO case definition for severe and very severe pneumonia could include children with a whole range of conditions presenting with respiratory distress. And while it was useful previously when the predominant causes of respiratory distress in children were bacterial in cause, there might be need to reevaluate the relevance of the classification of pneumonia and try and identify subpopulations of children for whom the guidelines might not necessarily apply. So I'm in the process of conducting an analysis using data from 14 Kenyan hospitals which form part of the network, which might lead looking at children with pneumonia. So over a 2-year period, I've managed to extract data from 17,000 cases of pneumonia admitted at these 14 hospitals and attempted to look at the risk factors for mortality within this population. And so in this slide, you can see numerous clinical characteristics define increased risk of death. So all the way from a young age group, female sex, to living in a high malaria prevalence area, severe pneumonia, increased respiratory rate, even elevated temperature, and most interestingly, moderate malnutrition, moderate pallor, and moderate dehydration, which would ordinarily be treated in the outpatient setting, appear to increase the risk of death among children presenting with pneumonia. And there is some supportive evidence from other reviews that some of these risk factors might increase mortality, and this should perhaps form a basis for the WHO seriously reevaluating the classifications of pneumonia, particularly in high mortality settings such as sub-Saharan Africa. So in summary, we think that the etiology of pneumonia might have changed following the introduction of particularly the pneumococcal and the Hib vaccines. We think comorbidity may play a major role determining clinical outcomes for children with pneumonia, and some of these questions are best addressed using pragmatic clinical trials to inform policy relevant questions within the region. Thank you.